We begin this procedure with a clear corneal side port incision, followed by a clear corneal 2.4 millimeter primary incision. Intraocular lidocaine is injected, and then viscoed. We'll be discussing the interesting morphology of this crystalline lens during the procedure. Next, Provisc is injected beneath the viscote, and the anterior capsule is opened with a straight 25 gauge needle. The convex anterior capsule, those of you watching in 3D, can appreciate that the anterior curvature of this crystalline lens is not flat. It's a bit steep, and those are the ones you want to watch out for, that they don't run out into the periphery, because they're kind of already headed downhill. So regrasp them frequently so you can maintain really good control over the direction of that rhexis. So there's hydrodissection done with that flat cannula and followed by viscodissection. Now, when I see a convex anterior capsule, I think the zonule might be lax. And when I think the zonule might be lax, I do things a little differently. I do 360 degrees of viscodissection, which is what I just did. So now we'll watch and see if we see any signs of zonular laxity during the phaco. With the chopper positioned at the side port, I have actually control of globe position and stability. And then once I get in and go to foot pedal position 1, I can usually get the chopper to pop in. Now, if I can't, what would I do? Because it might happen. It's a big ball chopper. Let me have the side port blade. So I'm going to slightly enlarge that incision, but I don't want to make a second one. So I'm going to go right at this opening and just do a little side to side like that, and then you can get in the same incision. And then I'll make it maybe a quarter or a half a millimeter bigger. And now I'll put the chopper in. And there's a lot of cortex there, so I'm going to remove that first. Quadrant removal.
Quadrant removal.
So I can see better. Because sometimes, you know, cortex just comes up. Sculpt. Okay, so now we're ready to put the chopper out over the equator, hold the nucleus still, and sculpt the bowl. And by focusing down, I can see the bottom of the bowl. And as soon as I get a pretty good red reflex there, I can chop without separating widely. You can see that I only had to separate about a millimeter. Without separating widely, that's nice to the zonule. Okay, now quadrant removal again. So I want to take out this first segment, because that decompresses the capsular sac. So I took a piece out of the pie there. So now every subsequent chop is done in a decompressed sac. And what is that? That's zonule friendly. So if I had to separate the instruments wider, I could, because there's a lot of play, room, space in the capsular sac because I took out the first piece. Okay, so now we'll just remove the other segments. Wet the cornea, please. So here I'm going to just focus up because I got a piece that kind of came up to the front. What do? I catch it, but then I go back down before I use ultrasound. Because the further you are from the endothelium when you apply ultrasound, the less the effect of the ultrasound on the endothelium.
As President.
Hey, doing great, honey. Nice and still.
Trees.
In fact, it's the square of the distance affects the power. So keep ultrasound away from the endothelium. And there are easy ways to do that. Just think of it, and you will. Okay, a couple of little pieces of epinucleus. Now we go after the cortex. And so far, happily, the zonule has appeared to be quite good. I didn't see any signs of laxity either during nucleus removal or now during cortex removal. Now, 12 o'clock, here's a little runner right there. I just kind of aspirated off. 12 o'clock cortex removal. Even though my chamber is very nice and deep, why take a chance? Put the spatula, there's a nice PSC there, you can see it, wet the cornea. So I'm putting the spatula right there. So there's really no way I can catch the posterior capsule because it was held posteriorly, right? Now this, I'll rub that off with the OVD, but before I come out, I'm going to remove epithelium from underneath the anterior capsule. And there's a lot of it here. So that reduces basically eliminates the chances of capsulorhexis contraction. So now to get rid of this PSC. This is a Provisc cannula. I'm injecting Provisc, and as I do it, and I gradually focus the microscope down, I rub it right off. And if you do this as you inject the OVD, it's absolutely safe. I've done it thousands and thousands of times. Don't do it dry, meaning you always want to be injecting. So now that PSC is not attached anymore. There's a couple little pieces of it hanging around, but now I can inject the IOL. And I'll aspirate that little epithelium with the INA tip after the IOL is in. So this patient is an artist and extremely color sensitive. These are the only patients, I mean 1 in 10 or 20,000, where I'll use a non-chromophore lens. Otherwise, I use it 100% of the time.
Wow.
And I've used the chromophore lenses in many artists, and they've noticed no color disparity. But this particular patient is a color artist non-pareil, for those of you who speak French. She's an amazing artist.
Thank you.
So we didn't want to even have any question of having any impact on her color perception. So now we'll do stromal hydration.
Should I still be looking over there?
Right at one of the 3 lights. Perfect. Hold it just like that. And now stromal hydration here. Depress the optic to do our best to have no stria in the posterior capsule. Check IOP, nice, stable, and we're done.